Hello, we are Team 5, and this is our presentation on Detroit perinatal health, a population health perspective. For our project, we are focusing on the city of Detroit, Michigan, with particular attention to pregnant people, birthing individuals, and infants. Detroit provides a powerful case study for population health because health outcomes are not evenly distributed across the city. Where someone lives, their income, and their race strongly influence maternal and infant outcomes, making Detroit an important community for understanding how social and structural factors shape perinatal health. When we refer to the community for this project, we are looking broadly at the city of Detroit, but also more specifically at neighborhood and zip code level differences. This matters because Detroit is not one uniform community. Different neighborhoods experience very different social, economic, and health conditions, which directly influence perinatal outcomes. So, with that context in mind, the question becomes less what the outcomes are and more why they look so different depending on where someone lives. This presentation is structured to answer that question in four parts. First, we briefly review maternal and infant health outcomes in Detroit. Next, we examine the key social determinants of health that explain these patterns. We then look at how the healthcare system is currently responding. Finally, we propose a targeted initiative designed to address one specific social determinant of health and improve perinatal outcomes.
To start, I want to briefly situate Detroit nationally. As you can see on this map, Detroit consistently ranks as the neediest large city in the US. This ranking reflects a combination of economic strain, unemployment, poverty, housing challenges, and safety concerns. Detroit has the highest unemployment rate in the country and some of the highest adult and child poverty rates, with nearly half of children living below the federal poverty line. These upstream conditions shape health long before someone becomes pregnant or enters the healthcare system. From a population health perspective, this tells us that poor outcomes in Detroit are not isolated or unexpected. They are the result of long-standing structural and economic inequities that affect access to basic resources like housing, transportation, and healthcare. This slide highlights how economic conditions in Detroit differ sharply by race. On the left, you can see how median household income by race in the Detroit metro area. While some groups have incomes close to or above the national average, Black or African American households have substantially lower median incomes, nearly $30,000 less than other groups. On the right, the poverty rate tells a similar story. Poverty is higher in Detroit than the US overall, and Black families experience the highest rates of poverty. In 2023, more than 44% of children in Detroit were living in poverty, compared to about 17% nationally. Poverty increases exposure to chronic stress and limits access to stable housing, nutritious food, reliable transportation, and consistent prenatal care, all of which are critical for healthy pregnancies and infant outcomes. This slide illustrates how strongly health outcomes in Detroit can vary by neighborhoods and zip codes. On the left, you can see life expectancy at birth differing dramatically across zip codes, sometimes by more than a decade within the same city. On the right, the map visually reinforces that these outcomes cluster geographically, meaning health is closely tied to the place that someone lives. These differences reflect a neighborhood level conditions such as housing quality, environmental exposures, access to transportation, and availability of healthcare services. For maternal and infant health, this means that where someone lives can influence outcomes as much as or more than individual clinical risk factors.
As we can see here, Detroit consistently experiences worse maternal and infant health outcomes compared to state lines and national averages. These include higher infant mortality rates, an increased rate of preterm birth, and just greater maternal morbidity. Importantly, these outcomes are just not random. They actually vary significantly by race, income, level, neighborhood, zip code. And that pattern reinforces a key population health concept that was taught to us during this course. That perinatal health is shaped by broader social and economic conditions, not just medical care alone. Next here, if one message from this data section lands, it is that the same city contains very different conditions. And those conditions can predict very different health outcomes across the board. We see economic strain, food insecurity, income gaps that just closely align with Detroit's perinatal disparities, with that burden of falling on specific race and neighborhood zip code groups. Place will act as a shortcut for exposure, as we've learned in this course, that housing stability, transportation access, and that availability of those support services vary dramatically by not just state lines, but zip code lines. Together, these patterns point to a population health problem that requires the system level and community-based solutions together as a team that goes higher than one individual. So not just an individual level clinical intervention, but state and city collaboration.
Another reason Detroit is well suited for this project is the availability of robust local data. Resources like Detroit's perinatal epidemiology reports and life expectancy maps allow us to examine trends, disparities, and patterns across neighborhoods. This level of data supports meaningful population health analysis and helps connect social conditions to health outcomes. This community overview sets us up for the foundation of the rest of our project. Understanding who the community is and where disparities exist allow us to next explore the specific social determinants of health contributing to these outcomes and how healthcare and public health systems are responding. These disparities make Detroit an ideal setting for a population health approach. The difference we see in perinatal outcomes cannot be explained solely by individual behaviors or clinical decisions. Instead, they reflect broader social, economic, and structural factors such as poverty, transportation access, housing conditions, and systemic inequities that shape health at a population level.
This slide here will highlight our efforts that align with a population health mission-based approach by rather addressing systemic gaps rather than the isolated clinical care that so many think is the solution to this. Initiatives such as the Michigan Perinatal Quality Collaboration focuses on improving outcomes by targeting social drivers of health and leveraging regional partnerships and community-based workforces, which can include home visiting programs and whatnot. So the Detroit Health Equity Education Resource also reflects another core course theme that we've learned in a group that can help leverage and make change. Is building capacity through education and shared knowledge is such a crucial part in fighting these battles. So this will allow providers and communities to be better equipped to address maternal and infant health disparities upstream, not only at the point of delivery or in the hospital room. Here we're going to look at it from another population health lens, our strengths and limitations of our current efforts. So these efforts demonstrate important strengths, particularly in using data. As you saw that rooted our case here, the amount of resources to our fingertips is immense. And these can help identify disparities and inform policy at more of a broader scale. However, one of our key limitations that we learned in class that was discussed that is many of these operate as at the system or statewide level, which can overlook specific neighborhood barriers and the actual context of what's going on in these neighborhoods. There's also a stronger emphasis on education and awareness, while fewer interventions directly address the day-to-day constraints that these families are seeing, such as transportation, housing instability, just our access to the supportive services that we mentioned earlier, which just further highlights the gap to better understand the problem and delivering actionable, localized support to these families.
With all of this context in place, we will move into our proposed initiative, the resources we anticipate will be required, and the impact we believe it will have on our defined community. Our review of Detroit's perinatal health landscape shows that while many supportive programs exist, gaps remain, particularly around transportation. Even when prenatal services are available, the ability to physically access care continues to be a challenge. Importantly, transportation barriers often extend beyond the pregnant individual to include childcare responsibilities, which can prevent families from attending appointments. Detroit currently runs a program that offers free round-trip travel to prenatal and postpartum visits up until the child becomes 1. This program takes advantage of rideshare companies to provide logistical support. This is an important program to attack social determinants of health head-on, but there are still gaps that can influence health outcomes. People taking advantage of this program are required to provide their own car seat for any children accompanying them to visits. For low-income patients and those without a car, not having a car seat or multiple car seats could limit their ability to attend appointments and get care. Based on this gap, our proposed initiative focuses on one specific social determinant of health: transportation access and continuity of care for pregnant individuals. This initiative is designed to support pregnant people who also care for young children, a group that faces compounded barriers for accessing prenatal services. This population is especially susceptible to missed appointments due to the spread of resources and time. We recognized how great the program Rides to Care is for increasing access to transportation for pregnant individuals. Our initiative leverages the existing program to help solve an additional barrier to care. The proposed expansion would designate a subset of rideshare vehicles equipped with child car seats, allowing pregnant individuals without access to a car seat to attend appointments with accompanying children. Referrals would be coordinated through healthcare-based social workers to ensure appropriate use and continuity.
This initiative aligns very well with existing healthcare systems capabilities. First of all, this initiative is aligned with the city's existing transportation goals. It will build on infrastructure currently in place, as well as rideshare organization cooperation. Michigan PQC's emphasis on system-level quality improvement provides a natural framework for evaluating transportation-related barriers, while DHERE's equity-centered education can support provider awareness and referral pathways. By integrating transportation support into existing workflows, this initiative enhances but not duplicates current efforts. Internally, the initiative would rely on care coordinators or social workers to identify eligible patients and facilitate referrals. They would be the first line to educating people on the new program. Existing schedule systems could be adapted to flag transportation needs. Some software developers and IT staff will be needed to help adjust existing programs to allow for new options. Externally, partnerships would be essential. Collaboration with rideshare and medical transportation vendors could ensure vehicle availability and fulfillment of the service. Partnerships with community organizations could support outreach and trust building. At the beginning of the program, it will be hard to educate the community, but these organizations are best equipped to bring the information to the people. Car seat suppliers and safety organizations would be needed to ensure compliance with child safety standards. There would also be opportunities for car seat companies and rideshare organizations to help donate supplies and offer discounts to the organization for rides. Resources that track the initiative would also be vital to understanding the impact. Real-time tracking would allow for better appointment scheduling. This includes statistics on how access could be increased and whether there are better health outcomes among the target population. Staff to perform these clinical trials tracking the outcomes would be necessary. By addressing transportation barriers more comprehensively, this initial initiative has the potential to increase prenatal appointment attendance and improve continuity of care. Increased attendance and continuity of care would have a positive impact on health outcomes for both the patient before and after birth. Reducing missed or delayed visits supports earlier detection of complications and more consistent prenatal monitoring. In summary, we have shown that there are significant systemic gaps in Detroit, especially in prenatal care. Income inequality, zip code, and transportation are some social determinants of health that we have shown to impact life expectancy and health outcomes. We proposed an initiative that translates population health insights into actionable change. We narrowed in on a problem that pregnant individuals with young children face. We proposed an initiative that provides transportation to appointments with child seats so the parents are not forced to buy potentially multiple car seats. By building on existing systems and addressing a specific social determinant of health, it offers scalable, equity-centered approach to improving prenatal outcomes in Detroit. Thank you.